Good morning, everyone. My name is Patty Urena, and I am the Director of Education and Outreach at Achieve a Family Trust. And we're so happy to have so many people joining us this morning for this very important webinar. The topic, as you all know, is Mental Health Advanced Directives and the 988 Crisis Hotline. Our presenters today are Jenny Vaporetti and Nikki Wygant from NAMI, and I'll let them, introduce themselves and talk to you about what they're going to be presenting on this morning. Jenny and Nikki will be able to answer your questions at the end of each of their presentations or throughout the presentations, however best works for them. So I'm going to stop my share and I will let Nikki go take over. And again, thank you, Nikki, for joining us and welcome.
Good morning, everyone. My name is Jenny Vaporetti, and I am the Adult Mental Health Advocate for NAMI Keystone. And today we're going to go over Mental Health Advanced Directives. We're going to talk about what they are, what the benefits are, how to tailor one for yourself or for a client to be most effective, and a lot of the ins and outs and how long they last, and providers' responsibilities, agent responsibilities. So we're going to just take it away here with the first slide. So Mental Health Advanced Directive in a nutshell is a legal document in Pennsylvania of an individual's wishes and preferences with regard to their mental health care and only their mental health care. And then, so we all have the right to receive treatment, consent to treatment, and refuse treatment. And a lot of the times, when I'm with someone who's refusing treatment or working with someone who's refusing treatment, it's important to talk to them about the consequences of that. And sometimes, I'm just going to say that some of these slides are a little repetitive for comprehension. So if I repeat something or get a little ahead of myself, bear with me. In terms of refusing treatment, it's just important to have a conversation about what the possible consequences might be. So for instance, if someone's involuntarily hospitalized and they're refusing medication, they have every right to do so. It's just important to let them know that it might extend their stay. So that's what we mean when we say people have a right to refuse treatment, except in an emergency, and it's important to know what the consequences would be. And then, I think a lot of us, either from our own experience or from working with our clients, we've come across people or been felt the way, that we forced to take medication, medication that they don't feel is best for them, that they've had a bad experience with, people that, you might be worried about who's going to care for my plants, who's going to take care of my apartment, who do I want on my support team? And sometimes, we all know that sometimes family, we don't always want family involved. Some people don't have family. And so it's very important that they have their friend or a partner involved in their discharge planning or as a part of their extended support team to be involved in their mental health care. So a Mental Health Advanced Directive, it's a written document of your preferences, and I'm just going to go over it's going to be the preference of hospital, doctors, medications, what might a bad day look like for you, and how can those around you help? What can everyone else do to get you through that bad day? And a Mental Health Advanced Directive is protection for when you are hospitalized. And it's just a natural and critical part of your wellness plan. And, you can attach it into the crisis plan. A lot of people do that. It's a part of the crisis plan. They attach it with their POA for their physical health care. So you have the mental health care piece and the physical piece together. And so it gets people more involved in their care. It builds trust. It makes people more likely to seek the care that they need. We'll go to the next, here we go. So there are three ways that we can create an MHAD. You have the declaration form, which is more defined, less flexible, and that would just be the individual making all the specific decisions. What meds they prefer, what some of their triggers are, their spiritual needs, their dietary needs. So, it would just be very, very specific. And whatever, if it's just a declaration form and some decisions need to be made that aren't clearly defined, then then the doctor would be making that decision if you just have a declaration MHAD with no agent assigned. Now, the next one would be the power of attorney form. Okay, it's more flexible and it requires an agent. You assign an agent to make all your little decisions for you. If you're comfortable with that, if you trust them to do so, or you can assign an agent to make some decisions, but not others. I know a few people recently that I've worked with, they assigned an agent only to make decisions that pop up, like as a wild card. Otherwise, they're very specific on what it is they do and don't want. And then, of course, the combination form, like, you can make certain decisions and then assign that trusted agent to do everything else, or be specific with what it is you'd like the agent to make decisions. Say, so say they only, you only allow them to make decisions about where you're going to go for treatment, the hospital, and nothing else. And you can do that. So there's a lot of wiggle room for tailoring your MHAD. So let's go to the next slide. And, do you want to make all your own healthcare decisions and treatments? I haven't met anybody that said they didn't. And I think a lot of people, when, with their own lived experience or they have a loved one, I know working with patients who are in hospital, a lot of the times they feel imprisoned. They'll use that kind of language. They don't feel like they have control. And to tell you, the MHAD is the best way to gain some control. And frankly, it's really the only way that you can have that kind of control over your mental health care if you're involuntarily hospitalized. And then you ask the questions, do you have someone you trust? With regard to an agent, sometimes, I've had people that, I've been with someone, it's my boyfriend for 6 months or my girlfriend for 6 months. And, I have to have that conversation with them that, it's a big decision, and you need someone to really know who you are, and to have that long-term experience with that person, so that you can be comfortable that they do know what your wishes would be, putting themselves in your shoes. And a lot of people do not have someone that they trust, and that's okay. And then with regard to agent, it's important, do they have transportation? Would they be able to show up on a whim? Do they want to be your agent? That's important, because some people will just assume, oh, I'll make this person my agent, and then when it comes down to it, that person's like, what? So it's important that to have that discussion with them, ask them that they're okay with it, etc. Do you want to make your agent? You want to prevent your agent from making certain decisions about your mental health treatment. We kind of covered that a little bit, but you can be very specific on what you do or do not allow them to do. Let's see. And to make one, you must be 18 years old. You currently you have to have capacity at the time, and you cannot have a legal guardian. Now let me back up for a minute. Currently needs to have capacity. Now, if someone's hospitalized, you can work on an MHAD with them, and I do that all the time. However, it cannot be effective. It cannot be put into place and rendered effective until the individual is discharged and regains capacity. And let me go on to the legal guardian caveat. You cannot have a legal guardian in place and make an MHAD. However, if you create an MHAD first, before there's a legal guardian assigned by a court, then it's best practice that the legal guardian will follow your MHAD. So I just wanted to make sure to mention that, if you have one MHAD in place, the guardian will see that. If you don't, have an MHAD in place and the guardian's there, there's really nothing you can do. You can't create an MHAD after you have a legal guardian assigned. So capacity for an MHAD is only related to mental health treatment. So you can't, make decisions that, with regard to your children, for instance. The courts would decide where your children go. So when you put that in your MHAD, who's going to watch my kids, that's very, very temporary. Just want you to know that. The capacity is the basic ability to understand, your diagnosis, the risks and benefits of your treatment. What are the alternative treatments to what it is that you're, looking to do with your mental health care? What are the consequences of not having any treatment? And with, it is assumed that everyone has capacity unless it's determined that they do not. And there must be 2 evaluations to determine that. There would have to be a psychiatrist and a social worker or another mental health professional that's working with that individual. So it's usually 2 people making that decision, evaluating the individual for whether they have capacity or not. And just let me say, when you're creating an MHAD, it only takes 2 signatures to make it a legal document. And by that, the 2 signatures can be a waitress from Denny's. They're not privy to what's in it, so they don't have to read what's in it. And the signatures are only witnessing your signature. They're not a witness or to your capacity in any way. And let me just say that again. You need 2 signatures. You write up all your lists, wishes, and preferences, and you get 2 signatures of people witnessing you sign it and date it. And then it's effective right then and there. But I just wanted to mention that, that those are your people you're getting to sign to witness your signature are not in any way determining your capacity or even privy to what is in your MHAD. Okay. So yeah, the person the client has chosen in an MHAD to make his or her mental health decisions when he or she doesn't have capacity would be the agent, and the client decides which powers that agent has. And you're going to get an little electronic booklet that I'll make sure you get that is agent responsibilities. It goes through that. An agent is someone who the client trusts to make the same decisions he or she would. Were they in her shoes, her shoes, sorry, can make the decisions based on discussions with the client and the MHAD and is available to make treatment decisions. An agent is not someone, it can't be an employer, a provider, an owner and operator of a residential setting or facility. And the agent cannot be someone who's witnessed your signature or signed as a witness. So those are the general guidelines for the agent when one is assigned. So you have treatment choices, the consent or refusal for mental health treatment. And it's becoming best practice right now for providers to comply with your MHAD. And typically best practice is to, if they're not going to comply or, abide by your wishes for treatment, that they, put something in your file as to why that is. And usually it's something that it's against medical practice or it's dangerous. But usually it's best practice now for providers to follow MHADs. So then you have, like we talked about, the choice of hospital, hospitals and doctors. And it's important to note that sometimes it's about the opening of beds, the availability. And it's important to discuss that might not always, you might not always get your choice of hospital or, doctor, etc. And I just want to go back to the listing medications, for instance, and how important an MHAD can really be in your care. Now, when I work with people who are hospitalized, I get the guinea pig statement. I feel like a guinea pig. I get that a lot. And it's what it is when you go in the hospital, most doctors, they don't have time to read your entire history. They're just going to know what are your allergies, etc. They're not going to read your entire mental health history. What they're going to do is they're going to see a class of psychiatric medications, and they're going to pull from this trusted class. Okay, let's try Zoloft. Let's try Effexor. They'll just pluck it out, right? It's like pin the tail on the donkey, for lack of a better term. But if you have in your MHAD, if you actually list in there, listen, I've taken Zoloft and this is what it did to me. It was not good for me. And it's always important when you make, preferences in your MHAD, you follow the who, what, where, when, why, be as descriptive as possible. And so if you put that in your MHAD about the medications and you're very, clear about what it did do to you and how it made you feel terrible and it wasn't the right drug for you, then when you get hospitalized, if you're hospitalized again, they know where to start. They know not to pick from that section or that class of drugs, so that's just an example of how critical an MHAD can be in your recovery plan. So let's see, treatment and preferences. Let's just go over the basics that are in there. You have the medications, of course, that's huge. Experimental therapies and treatments. Let me just stop to say that only an individual can consent to that. Even if there's no MHAD in place, the doctor's not going to sign people up for electric shock therapy against their will. You have to specifically state in your MHAD if you're okay with experimental drugs, experimental therapies, ECT, research studies. You have to be specific to get that treatment. Otherwise, it's a default no. You want to put in there, treatment history, what worked, what's a bad day look like, what's a good day look like. Some people put in their triggers, because I've had people that don't like to be in a dark room or they don't like their doors closed. Someone just recently, they wanted a little teddy bear and there was a little, can we let her have this? Can we not let her have this? But it was critical to her care and it was to her mental health care. So they ended up letting her have that with her. It's so important. It really does give you choices that you otherwise wouldn't have the opportunity to make. Excuse me so much. All right. So we have dietary needs, spiritual needs, who should be called, who's going to care for my children, who's going to be on my support team. And I want to just say, that everybody, if somebody's hospitalized already and they don't have an MHAD in place, you can request a second evaluation while you're there in hospital, only and specifically for the creation of a Mental Health Advanced Directive. So all's not lost if someone's hospitalized. If they'll do that evaluation upon request, that second evaluation, and they can determine, okay, well, we'll allow, okay, that's fine. We'll allow you to make the decisions about, your dietary and religious needs and spiritual preferences, your treatment history, your triggers, but not your medication. I'm just giving an example so that those who are making the evaluation, if they decide that yes, he or she has the capacity to create an MHAD, they'll either do it blanket or they'll give like certain conditions that yes, this person is able to make only these decisions, but not these. So like I said, all is not lost. If someone's hospitalized, you still can ask for a second evaluation while hospitalized to put an MHAD in place while there. Otherwise, if someone doesn't have capacity, as I said, don't let it deter you, because I work with people all the time who are in LTSRs, who are in hospital, and I work on their MHADs. We just can't put it into effect until they're discharged, until their capacity has been regained. And so we already talked about that. Like an individual has to specifically consent to these treatments, else it's a default no. And let's see, having an MHAD, it just gives people control over their treatment plan that they wouldn't otherwise have. It makes people feel more comfortable about seeking the help and asking for the help that they need. If they feel confident that hey, I have a MHAD in place, I'm not too scared about feeling like a guinea pig with the medication, because they're going to know where I'm coming from. And another thing is important. I've come across this too, where, we spend all this time working to create an MHAD, and then that individual doesn't want to give anybody a copy. And it's important to let them know that if it's not in their file, it doesn't exist. So then I work with them on who they trust, who's important in their life. And I encourage them to give copies even to their PCP, their psychiatrist, their therapist, their loved ones, if they prefer. If there's a friend, a close best friend, give them a copy. You want the extended support team in that individual's life to have a copy, ideally, but it is up to that individual. So if they want to create one and not give it to, not give anybody a copy, that's fine. I mean, you just got to explain that it can't come into effect if nobody knows about it. And also, it's been proven that people get better treatment faster with an MHAD in place. Like I said, there's no pin the tail on the donkey. They know where to begin. They have a better idea of where to begin when you get there. And then sometimes when we're in crisis, we're not always able to communicate what we put down in an MHAD. So that's another reason to have one in place, because, it's not always easy to gather your thoughts in the midst of a crisis, and you'll have everything right there. So yeah, and when you assist somebody in completing an MHAD, let me tell you, you learn things about that individual you probably wouldn't learn otherwise. So it builds a better bond between yourself and your client. And it creates more satisfaction in the mental health services and outcomes that people receive when they have an MHAD in place. And let me just say, there are fewer hospitalizations for folks who have an MHAD in place. And I think that's, maybe because people are ruminating, getting engaged, and thinking about what's good for them, what journey they're on, what their recovery track looks like. So I think that's why people are more successful when they have an MHAD in place. And, MHAD is working to create one. It's a billable service. So you can definitely do it while on the clock in your position. And some of the stats would be only 4 to 13% of outpatients clients have a completed MHAD. And I can't tell you, when I go, has anybody heard of an MHAD? And there's only a few hands that go up. So we're working to spread the news here. And because 50 to 60% of people with a severe mental illness would complete one if they knew about it. And some people express shock, like, oh my God, I never knew about this. So it's just important to mention it. And some of the barriers when you broach the subject of an MHAD with someone, it might be just difficult understanding an MHAD. And I hate acronyms personally. So when I'm like, do you ever hear of an MHAD? And people are just like, what? So, it's a mental health advanced directive. It's a big word. It sounds like legal schmeagle stuff. So I always broach the subject. I explain what it is. And sometimes people just aren't at the right place in their journey, in their recovery, to start creating one. And sometimes they just outright poo-poo it. But I don't give up because I realize that, along the course of recovery, people recognize and they recognize what it is that they need, that they, along the course of their journey, they'll realize that maybe this is a good idea. So I just keep bringing up the subject. Hey, have you thought about that MHAD? And I always encourage people to make lists while they're hospitalized. What do you like about your hospitalization? What don't you like about it? And then, a lot of barriers. Another barrier would be lack of a trusted individual, not having anyone to serve as an agent, which is okay. They don't have to. They can make specific all the decisions on their own, as few or as many as they'd like. And then the complexity of filling out forms, obtaining witnesses, making copies. Now, the Disability Rights Project and Mental Health America put out a wonderful template, and you'll get a copy of that electronically as well. Each section, the 3 sections, the combination, the power of attorney, and the declaration, Each section has detailed instructions, and the template's really nice because it kind of goes over the basics so that you don't miss anything with, meds, dietary, spiritual, hospitals. It's there to generate, make sure that you cover just the basics, but you can add to it. Long story short, you can create an MHAD on a cocktail napkin. It doesn't need to be this template or any specific template. I mean, you could do it on a piece of notebook paper, as long as those 2 witness signatures and your signature and dates on that, it's effective for 2 years. Now, that's another thing. I've been hearing talk of people wanting it to be 5 years, and I understand that, but right now it's 2 years. So once it's signed and dated, it's effective for 2 years. And then if you want to make changes at that point, make those changes. But if you don't, all you need to do is just get new signatures to witness your signature and a new date. That's all. So if there are no changes, just pull the signature sheet and create a new one. And sometimes it's good, like, to revisit your MHAD every 6 months or a year, just to see if anything's changed. And I was going to say something. The filling out forms and the witnesses. Bear with me here. Okay, go ahead. You can switch. All right. So yes. So most people, they talked about an orientation to MHAD concepts, a review of past treatment experiences, documentation of future treatment preferences with guided discussion, and assistance with completion of forms, obtaining witnesses, and filing forms in the medical record. So a lot of times I do have to make those copies and make sure that they have them, because they don't always have access to a printer. And I just want to say, with regard to the expiration of MHADs, this is my thought that I was trying to find. If you are hospitalized while the MHAD expires, it's not going to expire because you're hospitalized. So to say it will not expire until discharge, whenever that is. So even if it's past the legal expiration date, as long as you're hospitalized, it's still in place. So there's no worry in that regard. Let's see, right? So yeah, I mean, it's all about tailoring the MHAD to be most effective for the individual, asking them questions, encouraging them to talk about what worked for them, what didn't work, asking the who, what, where, when, why, getting as much detail as possible. The more detailed, the better. And to make certain that the MHAD is valid, you have to have it signed and dated in front of 2 witnesses who also signed the MHAD. You have to, people assist clients with making copies for providers, assist clients to make a wallet. That's the thing. On this template, that's this wonderful template you're going to get that you can choose to use or not. It has a little wallet card that can be filled out and placed in an individual's wallet or purse to signify, yes, they have an MHAD in place when a crisis occurs. So I like that part of it. And usually when you get that electronic template, you could just print it out. That's what I do. And I, start with that I present it to my clients and ask if this is something they'd be interested in this template, or I've had somebody just recently want to just do their notebook paper. They didn't want anything to do with that template, and that's okay. Let's see. Yes. It's important for providers to inform, to ask an individual, do you have an MHAD in place? And then to let them know what it is. And I think it's important to come from various angles, from the social worker, from the psych nurse, to ask, the supports coordinator, to have a few people from different angles asking, hey, do you have MHAD in place? And then, like we said, it lasts 2 years. You could make any type of revocation or amendment to the MHAD at any point in time, but you have to have a new signature sheet to make it in effect, put it into effect. Document any determination of capacity to make mental health care decisions and comply with the MHAD cannot violate clinical practice. So yes, it's best practice for providers to comply with the MHAD. You're going to get the template for the MHAD. You will get the provider responsibilities. What are providers responsible for? and what are agents responsible for with regard to MHADs. I think we're done, right? Are we done on this slide or no?
No, I just switched it to a new slide. This is continuation of provider responsibilities.
Okay, sorry. Okay, so I feel like we covered most. Oh, yes. Yes. Okay. Inform clients and legal representative if the provider cannot comply with something in MHAD. So yes, it's best practice to inform and put something in the file as to why they did not follow the MHAD. It's expected that providers make reasonable efforts to abide by the wishes. And also, if an individual is hospitalized and they're seeking care that's not provided by that specific treatment facility or hospital, they can ask and request a transfer to another facility or hospital that provides that specific mental health care, therapy, or treatment. And a provider can't accept or refuse to accept you or work with you, whether or not you do or don't have an MHAD. So, there can't be any discrimination of any kind based on whether you have one or not.
Jenny, it might be a good opportunity to pose a question. We had one question in the question and answer about, can a guardian do an MHAD for the individual? Can a guardian?
No.
Can you
That
talk
would be
about that? Yeah. Why?
Once a guardian is in place, it's secured. It's put in place by a court of law. That's the thing. So it's very specific on what a guardian's allowed and not allowed to do. And if there isn't an MHAD in place, there can't be one created because it's for the individual, right? For their preferences. So yeah, I mean, it's just not something that is able to be. They don't allow them to do that, because the MHAD is all about the individual, the client, right? The patient. It's their wishes, their concerns. It's their recovery plan according to how they feel it should go. And so, that's part of the reason I think, and the legality of it. The guardians have very strict guidelines to follow to be a guardian. And so like I said before, the caveat would be if you have an MHAD in place and a guardian is assigned, then the guardian will follow that MHAD. If there isn't one in place and there's a guardian assigned by the court, then you can't create an MHAD.
Thank you. We had
Go ahead.
sorry. We had another question. It was actually one of the questions I had too. Is this only valid in PA or out-of-state hospitals as well?
No, it's only valid in Pennsylvania. That's important to look up how other states do theirs. Other states are very different. They have different expiration dates, different names for it. Some call it a PAD, a psychiatric advanced directive. So it's very important to look up the laws in the state that you're looking, that you're seeking treatment in, and you can create one for the state that you go to. So you can have one in PA, right? You can have an MHAD created and in effect in Pennsylvania, and you can, look up and make sure that you talk with someone. Say if you're going to Ohio for treatment, you want to make sure you know what Ohio law is. Is there a mental health advanced directive that we can put in place that's free and easy to do for the individual with just signatures? So yeah, you can have one in Pennsylvania, and you can create one for the state that you're going in if they have that available as an option. Would that make sense?
Yes. Let's see, we have another question. Someone asks, how old do you have to be to create an MHAD?
18, or you must be emancipated. You must be an emancipated minor from the courts to do so. So I'm finding I'm working with a lot of senior citizens lately, and they're really interested in this for good reason. They're very shocked to know that they could do this, and it has given people a new lease, on seeking care. Because that's part of what MHAD does. It makes people feel more comfortable asking for help, seeking help, getting care, going to the hospital when they need to, because they know this is in place. They have this. Yeah.
So Jenny, this could apply to someone, for example, who has a cognitive decline, like perhaps dementia?
You would have to have capacity. You have to have capacity to do so.
Right.
So if there isn't a formal diagnosis of dementia and so, you could try it and hopefully no one will contest it. There might be a family member that would contest it. But I'd say it's worth a try, but yes, capacity. That's important. And like I said, you can still work on it with people who have, lack capacity. I think dementia is a different story. But if someone's hospitalized and is deemed to not have capacity, they can certainly work on one, so when they're discharged, put it right into effect.
Yeah. Another question that came up is, does the MHAD include people with substance use challenges?
Yes, absolutely. In terms of, for instance, AA, NA meetings are very important to some people. And, the idea of being hospitalized without that part of their support system is scary. So they, that's a huge part of their recovery plan. So they want to talk about that, what their needs would be around that. Do they need the meetings while they're there? Would they need some other kind of treatment if they're in hospital for that substance use? Because sometimes you do need something, if you're on certain medications and you go into hospital, it's a street medication or not legal. You need to let them know for sure, because you want to get that medical treatment to make sure that you can get the mental health care you need. You want to take care of that physical piece while you're getting mental health treatment. So it's important to put that in the MHAD.
No other open questions at the moment.
Yeah, and I, a lot of people think it's just for, if I talk to supports coordinators and social workers, and some of them do think, I don't need one, but I feel like everybody needs one. I have one. So, even if you're a provider or a healthcare worker, I think it's important for you to have your own. And to go through that process, it helps you better tailor it to others when you have done so yourself. And it could be as long or as short, it could be, we always want it detailed. More details, the better. Who, what, where, when, why. Someone say something? I thought I heard something.
No, no other questions at the moment on the Q&A.
And like I said, you'll get the templates and my numbers at the end of these slides, I believe, so that if anybody has any questions or would like any type of assistance in creating an MHAD, please don't hesitate to give me a call or email. You can shoot me an email.
Vicky, did you have anything that you were going to add to?
Myself?
I'm sorry, we did have one other question that popped up. Saying, could this document be in your electronic patient record?
Oh, absolutely. Yes. And yes, I would, have it in your electronically and also have paper copies and have that little wallet card, make a wallet card. So it's on your person. It's handed directly to, paper to people. And then it's also in your electronic records. So that's like a 3-pronged system there. It's just safer, best bet that way to make sure everybody knows, everybody's on board, and it goes as smoothly as possible. Of course, I think it would be up to the hospital or the facility on how they do electronic records, but you can request, I would like this put into my electronic record as soon as possible.
And I just wanted to say, Jenny, NAMI has really been our go-to resource for so many people that we work with who, are calling and they're not sure where to start with whatever their situation is involving themselves or their loved one, in a mental health crisis or not in a mental health crisis. So thank you for everything that you guys do, because we've referred families to you and they've come back and told us how much you guys helped them and, really assisted them in this journey. Cause that seems like that is what it is. It's just a journey with a lot of peaks and valleys. And I think we're so lucky to have NAMI here. And I know you guys are statewide, but it's just a wonderful resource. So thank you for everything you do.
Yes. And we have the helpline that runs from 9 a.m. to 2 p.m. So if, there are families or individuals struggling to navigate the mental health system, parents of adult children, that's a typical call that I get, who won't take meds or won't seek treatment. So yeah, if you do anything, please give me a call.
Thanks, Jenny.
Thank you.
So I think Nikki's up.
I am up, and I don't know if you noticed this, but my camera just froze and turned purple on me. So I'm going to be off camera, and I really apologize about that. I'm going to go ahead and start sharing my screen. Okay, I should be in big mode now. Hopefully I am. So, hi everyone. My name is Nikki Wigan. I am the Director of Advocacy and Public Policy at NAMI Keystone, Pennsylvania. So, tying in what Jenny just talked about with the Mental Health Advanced Directive and being in a mental health crisis, 988 is the new mental health crisis number. I say new, but it's been around for 2 years. However, we're finding a lot of folks do not know that 988 exists. So, a mental health advanced directive is a very practical and handy tool to have when you do find yourself in a mental health crisis in need of assistance and having to call either 911 or 988. So I'm going to be talking about 988 today, the Suicide and Crisis Lifeline. As I mentioned, I am from NAMI Keystone, Pennsylvania, and the National Alliance on Mental Illness is a nationwide organization with over 600 affiliates across the United States. Every state, with the exception of 2, has a NAMI state organization, which NAMI Keystone, Pennsylvania is for the Commonwealth. So we're a 501c3 grassroots nonprofit org dedicated to improving the lives of children, adolescents, adults, and families affected by mental illness through recovery-focused support, education, and advocacy. So we're touching on all of those today. The recovery-focused support with mental health advanced directives, education, because we're teaching everybody about the tools that you need to, I don't want to say have a successful mental health crisis, but make it better than what a mental health crisis has been in the past. And advocacy. As Jenny mentioned, she's the adult mental health advocate for NAMI Keystone. And again, I'm the Director of Advocacy and Public Policy for NAMI Keystone, Pennsylvania. Just in the Commonwealth alone, we have 23 affiliates. And we're bringing new affiliates online what feels like monthly. We've currently got 2 more in the chute that will cover more than northern and eastern parts of the state. And our goal is at NAMI, of course, that all 67 counties within the Commonwealth would have a NAMI affiliate. However, we have some very large regional organizations that are serving people in all corners of the state. So why 988? It's super important because we need a compassionate and resourceful response to those having a mental health crisis. Law enforcement are ill-equipped and untrained to handle a serious mental health crisis, which we'll talk about more here in a little bit. A lack of an effective mental health crisis system. Also, going back to the law enforcement thing, 1 in 4 deadly shootings in the last 5 years involving law enforcement have also involved somebody with a mental health condition. Just in Pennsylvania alone, since the pandemic, there have been more than 20 incidents of, I just lost my word, of inappropriate use of force. That's what I'm looking for. So an estimated 44% of people in jails, and 37% of people in prison have a mental health condition, with more than 2 million people with mental illness booked into the nation's jails every year. And also during a crisis, it's a lot easier to remember 988. Like I said, we have 911 for any other type of emergency. So 988 is a lot easier to remember than the previous 10-digit number, which I don't even remember, honestly. I have a really hard time remembering phone numbers. Thanks now to my little pocket smart machine that tells me what to do and when to do it and who to call and gives me those phone numbers. So, and of course, we're not always going to have our cell phones handy that we're going to be able to hurry up and look up what is the suicide lifeline, crisis prevention number. So 988 is a much easier number to remember than the previous 10-digit number that was in use. So real quick, a timeline. In August of 2019 is when the Federal Communications Commission recognized 988 as a viable tool and option for those having a mental health crisis and working with SAMHSA, they were able to bring it online. So technically it has been active since August of 2019. So we're looking at almost 5 years now. However, legislation wasn't passed until 2020 during the pandemic, in June actually, requiring states and telecommunications carriers to all switch to 988. And that was an important piece of the puzzle in mandating that everybody start using 988. Cell phone carriers, of course, they didn't want to incur the cost of adding, another emergency line to their systems, etc. So with that federal legislation and that mandate, it brought it all more to fruition. It's also important to know that in the 2020 legislation, the federal government gave states the power to implement their own crisis continuum, which we'll talk more about the crisis continuum here in a second, as well as the mechanism, gave them the power to establish a mechanism in which to pay for 988, the call centers themselves, services that go along with dialing 988, etc. So soft launch of 988 occurred in July 2022. That is when all states had to be online with call centers ready to answer and go from there. So they called it a soft launch because it wasn't publicly advertised. Public advertisement didn't occur for 988 until July of last year. That's when we started to see billboards pop up. That's when we started to see it more on social media. That's when we started to I've even seen TV commercials. I've heard radio commercials about 988 and the benefits of calling 988. So July of this year, 988 just turned 2 years old. And it's such a monumentous occasion because of the amount of increased traffic that has occurred over the previous suicide crisis lifeline, again, that 10-digit number, and now having that quick 988, that 3-digit number to be able to call. Since the launch in 2022, so in just 2 years, 988 across the country has made more than 6 million contacts with individuals experience a mental health or substance use crisis. So 988, again, just isn't for a mental health crisis. If someone finds themselves in a substance use crisis as well, they're also able to call 988 and limit that typical response, which we'll talk more about here in a second. So short term, the goals have been to strengthen and expand the current Lifeline Crisis Center. Again, that's run by Vibrant. I haven't mentioned that yet, and I apologize. Vibrant is the administrator of the entire 988 call center organization, if you will. They have the network of all of the call centers. They oversee all of the call centers. They facilitate things that they need, provide technical assistance, etc. So these call centers are to be staffed with crisis counselors and establish not only the call centers, but text and chat options as well. Those are currently available within Pennsylvania. And I say currently available within Pennsylvania because there are call centers within Pennsylvania that are also able to answer the text and chats as well. That's not a feature that's available in every state. So for example, if you're calling from, say, Montana, just pulling that one out of the hat, you're texting or you're using the chat function, somebody in Montana may not be answering you. You may be receiving, crisis care via text, via the text or chat from, I'll use Resolve in Pittsburgh as an example, as they have the capabilities to answer the text and the chats. So long-term 5-year goal, again, from 2022 and the started is to build a robust crisis care response system across the country that links callers to community-based providers who can deliver a full range of crisis care services, and if needed, send people out like co-responder teams, etc. So we're in Pennsylvania, we're kind of in the middle of the long-term goal. I'll talk more about the programs and what we're seeing across the Commonwealth right now that's currently being utilized and where we can go from here to improve the system. So the ideal crisis response system, and this is per SAMHSA, has 3 components to: someone to talk to, someone to respond, and somewhere to go. So I'm going to take a few minutes to walk you through all of these and let you know exactly what that looks like and how it looks in across the Commonwealth, more importantly, as these are the resources that are going to be responding to you in your time of need and the resources that are going to be responding to your neighbors, etc. So someone to talk to, that's 24/7 local crisis call centers. Currently, we have 12 across the Commonwealth. I say currently as that number has fluctuated from time to time based on staffing needs, capacity, etc. And I'll talk more about staffing here in a little bit. As you know, the healthcare field in general has been at crisis levels as far as staffing is concerned for years, and the pandemic only exacerbated that. And now, especially within the mental health field, we find ourselves struggling in that a majority of the Commonwealth is considered a service shortage area when it comes to mental health providers. So again, there's 12 across the Commonwealth. I'll show you a map here on the next slide to let you know where they're indicated and who covers what counties. They're staffed by individuals trained to deal with behavioral health and substance use disorder crises. It's important to note that these individuals that are coming online to answer these calls, to answer these texts, to answer these chats, do not necessarily have to be trained counselors right now. For example, someone who maybe just has like a associate's degree in sociology, for example, and this is something that they want to get into. They don't need that master's degree in counseling. They don't need that master's degree in social work, etc., to be able to do this job, because there's a robust training program that comes along with being hired into this position. The current standard is 80 hours. So that's 2 weeks of intense training on how to deal with someone having a mental health or substance use crisis. And I will say too that, and this is, I think this is phenomenal and a barrier reducer. The Commonwealth is taking steps to put all of that training online so that you can do it self-paced. If you need to go back and look at something, you have the ability to do that. But just to let everybody know that these people are highly trained individuals that are answering these calls, texts, and chats. The ability to dispatch mobile response teams is needed. You'll see below that between 80 and 90% of all calls are resolved through conversation, which is outstanding. Because you don't get that when you call 911. 911, their initial and their job is to handle that as an emergency and dispatch someone appropriately. And when I say dispatch appropriately, I'm thinking like medical emergency, the house is on fire, etc. The dispatch for 911 to a mental health crisis is not necessarily appropriate all the time, and we'll talk more about that here in a second. Another important thing about the local crisis call centers, they have the ability to connect callers to local resources and schedule appointments for them, even if it's something as simple as an intake appointment. One of the larger call centers in southwestern Pennsylvania is Community Resources Center out of Butler, Beaver County. I always get my B counties backwards, so my apologies. But they're connected so far into southwestern Pennsylvania, and they have that ability to schedule initial intake appointments for some providers. It's not every provider, it's some providers, but it's very promising that between 80 and 90% of these calls are being resolved through conversations. And again, 988, I'll tell you this, isn't just an emergency behavioral health crisis line. It also serves as a warm line. If you're having a bad day, like Jenny talked about, if you're having a bad day and you need someone to talk to, you can call 988 and let them know that, hey, I'm not having a great day. They have the matrix, they have the criteria to determine what requires a mobile dispatch and what does not require a mobile dispatch. So, that can easily be another tool in your self-advocacy toolkit, knowing that line exists during your therapist off hours. Like if you need support at 2 a.m, you can dial 988 and get someone to talk to. So, and I will also say, and this is very promising, nearly 90% of all calls originated in Pennsylvania are answered in Pennsylvania. And we'll talk more in a second about why that's important. And I say nearly 90% because consistently our number has been like 89 point something. Always over 89, but not quite to 90. And I attend monthly calls at the state level about 988 and what's happening operations wise. We do 988 calls on the advocacy side to, you know, what we're seeing within the community, what we're hearing within the community, and what users within the community would like to see more of as far as 988 goes. So as I mentioned, this is the current coverage map of what's happening as far as call centers go. As you can see, like up in the Northeast area, there's one call center for several counties. There are a lot of larger counties, such as Allegheny, Philadelphia, that have their own in-house call centers. As I mentioned before, all Allegheny 988 calls are answered by Resolve. So if you do dial 988 within Allegheny County, I say within, but there's a caveat to that, and I'll get to that here in a second. Your call is most likely going to be answered by Resolve. And again, they have the ability to do the texts and the chats at Resolve also, which is huge for the younger generations because, and I know I'm guilty of this sometimes too. I do not like talking on the phone, especially when I'm having a bad day. So having that option to text or chat somebody if I need that additional mental health support, it could be critical. Because it's a lot easier, and I'll say this as somebody who's recently had some heavy things going on and needed additional support. I didn't have to dial 988. I will say that I have a wonderful support system available to me, but you know it's hard to get out exactly what your needs are if you're having a panic attack, if you're crying uncontrollably, things of that nature. So that's when the text and chat function definitely comes into can come into play and be more beneficial. So you see all of that purple stuff that's on the screen. I'm waving to my screen like all y'all can see me. All the purple right there is covered by the CRC, the Community Resources Center in Butler County. It's on my slide. Okay, so and as you can see, we have a pretty far reach, even out to Lehigh and Bucks. I will say at one point in time there was a call center in Bucks for Lehigh and Bucks County. However, again, mentioning the staffing issues, they were having a hard time keeping it staffed, so they're currently pausing operations and are serving as a local crisis line. I also knew too, again, that there are more call centers scheduled to come online in the very near future. I know that one is currently being worked on for the capital area, if you will. So that would respond to calls in Dauphin County, Cumberland, and Perry. So someone to respond. This is a critical piece of 988. And it's a critical piece because, again, going back to a 911 response versus a 988 response. 911 responses are usually pretty dramatic when someone's having a mental health crisis. To use my own, again, situation, I had to call 911 for somebody who was having a mental health crisis. In that response, during that response, I had no less than 5 police cars parked in front of my house. I had a ambulance, I had a fire truck, I even had sheriffs come to my house, just because I had to call 911. And this was in the end of 2020 before 988 had come online. So the goal with 988 is to move away from the police response and get a more appropriate response. So again, these mobile crisis teams, those are staffed by mental health professionals. There are a lot of co-responder teams that include medical personnel as well as peers, as well as a licensed counselor, a licensed clinical social worker, things of that nature. Their goal is to de-escalate the crisis situation and connect individuals with crisis stabilization services. And we'll talk more about those here in a second. They also work closely with law enforcement and only involve them in high-risk situations. And when we talk about a high-risk situation, we're looking at that person is actively a danger to themselves or somebody else. Those are the high-risk situations in which law enforcement are going to be involved. There's a model currently being used out west in Oregon and Colorado that I know of for sure are called CAHOOTS. And that's exactly what that is. It's a co-responder model with the mental health professional, the medical personnel, and the peers going out to answer these crisis calls. And they have an amazing engagement rate of not involving the police. The last statistics I saw, in 12% of cases of more than 100,000 calls over the year, law enforcement needed to be dispatched as well. So that's phenomenal. Because as I mentioned again at the beginning of the presentation, anytime law enforcement gets involved, it has the opportunity to turn messy really fast, and someone could get seriously hurt, injured, or even, die because of that situation. So again, excuse me, here in Pennsylvania, there are a lot of co-responder models that are popping up. I know in Dauphin County, I'll talk more about crisis intervention teams here in a second, but we had a training last week in Westmoreland County, and we had an individual from Dauphin County join that training with us, and she is a co-responder. Her job is to ride along with the police and answer mental health calls with them. That's solely why she's there. The police are there as her backup, but it's her job to go out and respond to these mental health crisis calls. So crisis intervention team is a huge model. It's been around for more than 40 years. It was initially started in the Memphis, Tennessee area in partnership with the local Memphis PD and NAMI, the national organization, and the local affiliate there. And what that is it is a specific training for law enforcement officers in how to deal with individuals in a mental health crisis. And when I say deal, I don't mean that in a bad way. How to use tenderness, how to use some compassion, how to use, de-escalation skills instead of, again, excessive use of force. We're immediately going to go for our firearm, and because all that does is hype everybody up. Obviously, that law enforcement officer at that point is in a heightened state of awareness and security. The person that is having the behavioral health crisis that we're responding to, that could escalate them as well. So what we do with the crisis intervention team training is, again, train law enforcement officers how to use some compassion, how to use some care, how to de-escalate the situation without having immediately to resort to using your firearm in order to do so. So within Pennsylvania, 42 counties have their own individual crisis intervention team programs, and there are several regional programs as well. With the regional programs in the Southwest region, the Southwest region covers all of the 6 surrounding counties outside of Allegheny. They've got a phenomenal program. I frequently assist with their CIT program. Just a personal brag, I guess, if you will, shameless brag. I am a veteran, and I did 8 years in the Army. So they have a veteran specific panel, and I usually go in and I share my experiences. As I mentioned previously, I had to call 911 for someone in my family who was also a veteran. And I share that experience of how well it did not go in order for them to understand the value of the training that they're receiving. So I mentioned at the bottom here, there's currently a pilot underway for youth specific CIT. And I'm happy to say that NAMI Keystone, myself in particular, has been in charge of developing that pilot program and piloting in four very specific areas across the state of Pennsylvania. So last week, as I mentioned, we did our first pilot program in Westmoreland County. We trained 26 officers, well, not even necessarily law enforcement officers. We're talking school resource officers, we're school assistants, school SAP coordinators, CAFS coordinators, anybody who interacts with youth that might be in a mental health crisis. And in getting this training for people who interact with youth frequently, is again another advocacy tool to prevent them from winding up in the hospital unnecessarily, winding up in some sort of incarceration unnecessarily. We even had juvenile probation officers that were joining us, just because, a lot of times, youth are acting out because of their emotions, because we don't give them the tools to properly communicate them. We don't give them the coping skills to properly deal with those emotions. So a lot of times, in behavior type situations with youth, that's what's happening. It's their mental health. So educating those officers and how to deal with a youth in crisis, it could bring a tremendous value to the crisis response system. And finally, we have somewhere to go. And these are 24/7 crisis stabilizations, and they provide short-term observation and stabilization. A lot of times the window is 72 hours. I know this isn't a webinar in 302s, but that's the standard within Pennsylvania, that, you have 72 hours to make a determination on somebody who has brought in for an evaluation under a 302. So those are those crisis stabilization centers. There are also trauma-informed programs. As we know, a lot of times that's what's happening with somebody. This is reaction to some sort of trauma. It could be a trauma that had occurred in the past, and they have been triggered by something in their life that has kind of, gave them a hiccup in their mental health recovery. So, and it's a warm handoff to follow-up care. And it's not just leaving somebody at the emergency department to languish for however long, and I'll talk more about that here in a second. It's taking the care seriously. It's the first responders, the co-responders, exactly doing that, making sure this person is in line to get the care that they need. So some of the SAMHSA best practice models, in particular the ones that are being used here in Pennsylvania, include peer respite care. So those are peer professionals that are in these areas, are designed for individuals to go, and they receive not only, the psychiatric support that they need, and the interventions that they need, but these individuals are also peers. So they have that lived experience, or they're supporting somebody with that lived experience of a mental health condition. Mental health urgent care centers are another thing that we're seeing popping up, more so in the populated areas within Pennsylvania. Resolve is considered a mental health urgent care under the SAMHSA best practice models. And that if you're, just like a regular urgent care, like Med Express, I'll just use that because it's down the street from my house. If I burn myself, if I break an ankle, if I have bronchitis, I can walk into Med Express and get seen. And they're gonna fix me up. They're gonna get me back on the way, and we're gonna go from there. So also crisis stabilizations. These are more, your long-term type of things where they're gonna get you to the point where you're stabilized. Am I still here? Can you guys hear me? Did you lose me?
No, we can hear you, Nikki.
I can hear you.
Okay. I lost the little picture boxes along the side of my screen. And I was like, oh no, did it boot me off?
Nope,
Okay.
you're still with us. Thanks.
Okay, awesome. Okay, so yeah, crisis stabilization units. These are your more intense type of things where, again, it could be a more long-term thing, but the intent is for you to get stabilized in the current crisis that you're in. So that way, again, you can move on to something long-term. This could even be like a crisis stabilization unit, could even just be a triage in a more long-term setting. Okay, so the intended outcomes in the 988 system: keep people out of hospital emergency rooms. I briefly mentioned that. I had the privilege of being part of a government mandated study about emergency department boarding for individuals with mental health conditions. It's a problem. There are a lot of times, especially in more rural areas, where psychiatric doctors' evaluations may not be readily available. A lot of people will get stuck in the emergency department waiting for something to happen. Worst case scenario we've ever heard was more than 30 days, where someone was stuck in an emergency department waiting on the treatment that they needed, waiting to receive that evaluation, waiting on a bed at another institution that was better able to care for that person. So that's one of the goals of 988, is to keep people out of that situation by offering them more practical options that are designed to care for somebody in a behavioral health crisis. Also, let law enforcement focus solely on public safety. That's why they're there, to serve and protect. Let them get back to that. Let them deal less with people in a mental health crisis, and let them deal more with actual emergencies. It also reduces high rates of suicide and incarceration related to mental illness, especially incarceration. Again, that's a lot of the solution. Someone gets a 911 call, someone's doing something, it's directly related to their mental health, but again, the cops don't have the know-how. They don't necessarily have that training to be able to make that determination. And again, we're either going to take them to the hospital or we're going to take them to jail. So let's keep people with mental health out of the jail so we can avoid increased suicide rates and the overall incarceration of people with mental health conditions, because we know that they're not going to receive the proper treatment that they need while they are in jail. Just an example of that, Jenny talked about medication preferences during the MHAD presentation. There's a very limited formulary. And when I say formulary, I mean the availability of certain medications in the jail system. So, you might have somebody who's been taking something for years and it's worked for them. Maybe they're off their medication, maybe they ran out, maybe their insurance lapsed, all kinds of things, and they were unable to take that medication. But they need to, if they're back on it, they'll be stable and they'll be out of harm's way. So not all jails, especially within the state of Pennsylvania, there's a very limited formulary that covers the entire Commonwealth. They might not have that ability to prescribe that specific medication because, again, it's not in the formulary. So that person is just going to sit in jail again in language. They're going to decompensate even further than what they already have. And then at that point, people start acting out because of their mental health. Maybe they get thrown into solitary confinement, which thankfully we don't have anymore in Allegheny County, but it's always a possibility. So again, intended outcomes, keep people out of the ED, let law enforcement do their job, and reduce rates of incarceration. So 911 versus 988. Excuse me, I almost said 918. 911 versus 988. Similarities. Both are a 3-digit emergency response number that dispatches the service. Both are funded through a telecommunications surcharge, but that's where the similarities stop. So 988, the call centers that are answering these phone calls provide a service. As I mentioned previously, 80 to 90% of calls, all calls are resolved within that call. So no service is needed to be dispatched. That 988 operator can hook somebody up with an intake appointment. Maybe they're, going to the social determinants of health. Maybe they're lacking in food. Maybe they're about to have a utility shut off. Maybe their mortgage is behind and they've received a foreclosure notice. So, and all those, the more things of that nature that are happening to you at any given time, the more stress it puts on your mental health. So these call centers can provide those services. They can link somebody up with, utility assistance, food assistance, mortgage programs, things of that nature, just to kind of get them through that current situation. They dispatch mental health mobile services, but only when needed. Again, if you're calling 911 and they consider it an emergency, they're sending somebody out. And like I mentioned, they're going to send everybody out. 5 cop cars, a sheriff, an ambulance, and a fire truck, just in front of my house the time I had to call 911 because of a mental health crisis. And living in a very small town, I live in a very small town along the Ohio River in Ohio, and people like to talk. So that was a very uncomfortable situation. And there's already a stigma surrounding mental health. So the following morning when all the neighbors, oh, everything okay? I saw all these cops, etc. at your house last night. How do you handle that situation? I'm already incredibly vulnerable. I've just helped a loved one through a mental health crisis. It's a very difficult situation to navigate. So a 988 specific response is keeping the law enforcement out of it, or, if you have a co-responder model and law enforcement is responding, that's somebody who's CIT trained, like we talked about, the crisis intervention team training. So they know exactly what to do in a mental health crisis. So it needs to be that one person that responds. Again, extension of resources and referrals, as I mentioned during the first point, if somebody calls, they need help with food, etc. 988 call centers have that ability to refer them to another organization within the community to kind of help them resolve that and maybe like lessen the burden of the current crisis that they're going through. And again, intended to resolve crisis within the call. Enough can't be said about, calling 988 and you're having a crisis and somebody's able, because they're there and they're trained and they're able to help you work through that crisis at that time. So that way we don't need to get anybody else involved, again, reducing the stigma of being in that crisis. And just, it's a warm hug. It really is. I do have received anecdotal evidence of people who've called 988 and talk about their experiences. And that's what they talk about. It feels like somebody's hugging them through the phone. They're just able to provide that comfort and support that that person needs. And they're able to provide, if law enforcement or another dispatch is needed, they're able to provide that comfort and support via phone until somebody else gets there and can further assist them. So funding, something of this magnitude is going to require a lot of money to effectively and successfully pull off. So the federal government, since they've mandated this, and we call them unfunded mandates is the best way to put that. They've been initially, like we said, it was an unfunded mandate. They left the power up to the states to create their own funding mechanism. However, in the meantime, until all states are able to do so, they've been pumping a lot of money into the crisis system, which is phenomenal. Since the inception in 2020, when all of this first started, the federal government has allocated more than $1 billion to 988 services. And most of that is into call centers to get them up and running, to make sure that there is someone to call. Someone answers that phone when the 988 call is going through. The federal government also mandates that states must spend at least 5% of their mental health block grant funding on 988 services. So how that looks in Pennsylvania is not call centers, excuse me. We talk about somewhere to go, mental health urgent care centers, getting together co-responder teams, things of that nature. That's where that 5% of that mental health block grant money is supposed to go. And that's exactly what Pennsylvania is currently using it for. And then another $640 million has been proposed for the fiscal year 24-25 budget. However, we're not there yet. The federal government barely passed their own budget last year. So we'll get there, hopefully, before the election, because that's going to be a big thing, but I won't get onto that soapbox right now. Just make sure you're registered to vote, because it's National Voter Registration Day. So as far as state funding goes, in addition to that mental health block grant money, there's currently a House Bill 1305 that is sitting in the Senate, that has been sitting in the Senate since last June. The House passed it unanimously and rather expeditiously, but it would create a 6.5-cent user fee per line, like the fee for 911. So everybody in this room that has a cell phone or a landline, if you still have a landline, every month when you get that bill, there's a 911 fee on there. And the 911 fee goes to, the call centers. It goes to providing services. It goes to, local fire departments, all those things that constitute a successful 911 call. So that would be the purpose of the 988 user fee. I will say, however, that advocates at NAMI and across the state of Pennsylvania have argued that that's not enough, but it's definitely a good place to start. So at the end, I always do a call to action every time I'm doing one of these types of presentations. So more on that here in a second. So there's also $5 million that was included in the governor's current budget that will supplement those mental health block grant services to expand crisis services, more money for co-responder teams, again, mental health urgent care centers, pure respite care, crisis stabilization units. So all of that money to go there. There was some other crisis money that was included in the initial proposed budget. However, it didn't make the final cut because of that funding that's coming for call centers from the federal government. So ongoing challenges. In a perfect world, we wouldn't have any of these problems. However, here we are. I just mentioned state legislation. It's been sitting for more than a year unlooked at. Like I said, it passed the House. It got its first read on the Senate floor at the Pennsylvania level, and then it's been sitting in committee since. And I don't know if there's any hope for it to be passed before the end of the current legislative cycle, which will end, 2024, the end of. So 2025, we'll start a new legislative cycle. So we'll have another 2 years to hopefully get this legislation across the finish line, because it's not going to continue to be a successful program unless it is properly funded. So misinformation and lack of knowledge. A lot of people don't know what 988 is. I run into mental health providers that don't know what 988 is, and it blows my mind. I'm like, how can you not know? I had surgery last year around this time, and I'm in the the post-op recovery room, and I'm talking about 988 to my friend that was my escort for surgery that day, and one of the nurses comes by and like, what were you just talking about? And it turns into me going to my local hospital to give a presentation about 988 so that their doctors know. I mean, I talked to, like, during that presentation, I, briefed surgical teams, there are ER doctors there, security at the hospital, just telling them about 988. So I mentioned staffing. Staffing continues to be a huge, huge, huge problem across the behavioral health, mental health spectrum because, again, it doesn't pay well for some reason. You think, with teachers, like mental health professionals and doctors, like we'd be top of the ladder because we're doing a very important service. However, we're seeing a mass exodus, especially since the pandemic, of people leaving to go to higher paying jobs. And those higher paying jobs are things like Sheets. They're things like Amazon. They're things like Target. You can work at Aldi for $25 an hour being a cashier. So a lot of people, like I said, we're seeing a mass exodus going that route. And again, it's been bad for a while. However, the pandemic only exacerbated that, and more people were leaving the field. So geolocation, this is very important to understand. And now that I'm thinking about this, I probably should have done its own slide on geolocation, but I'll do my best to explain this. So currently, as I mentioned, I live in Ohio. I have a 304 area code number, which is West Virginia. I can see West Virginia out my front door right now currently. And I work in Pittsburgh. That's where our NAMI Keystone office is located. So if I were in Pittsburgh at work and I were dealing with an individual that was having a mental health crisis and I had to call 988, my call would be immediately connected to Charleston, West Virginia, based on my 304 area code. Why is that a problem? Because I'm not in Charleston, West Virginia. I'm in Pittsburgh currently. So I should be going to resolve because that's who's going to be handling the person or the person's individuals that I might be working with at that time that are in crisis. So, and again, that's if I call from my personal phone. So, another example, if you have a 412 number and maybe you have a child or you yourself is getting ready to move across country and you're in California and something happens and you need to call 988, again, your 412 phone call is going to be redirected back to Resolve Crisis Center in Allegheny County. So Resolve isn't going to be able to be very effective in helping you get through your mental health crisis if you're actually calling from California. So the fix to that is geo-routing, which is a not new concept, but new concept as far as 988 goes. So what geo-routing does is it pings the most recent cell phone tower that you hit off of. And that gives first responders a better idea of where you might be located at. It also allows, geo-routing would allow more effective routing of your call. So if I were calling from my 304 number, but I'm in the North Hills of Pittsburgh at the NAMI Keystone office, I would, it would direct me to the more appropriate call center to receive help from. So the 911, 988 interface. So that's important. And then 911 is still going to get mental health calls until people know more about 988. That's just, fact of the matter. There's nothing that we can do about other than educate people. And I'll talk more about that here in a second. So how do we get the two systems to work well together? There are some 911 call centers currently in the Commonwealth that have mental health therapists, responders on staff, that if something were to happen, if they were to get a behavioral health call at the 911 center, they have somebody there who's trained, in mental health counseling, etc., that can take that call. However, how do we get the two systems to actually interface? Is there a certain script we need to follow for 911 to determine if it's a behavioral health crisis so we can do a warm handoff to 988 and then they can handle the situation? Like, how do those two systems interact? Because again, they're both emergency response lines, and people, as I mentioned, are going to continue to call 911 in an emergency, behavioral health emergency as well, until 988 is more talked about. And again, that last bullet point, steady funding, especially at the state level, because the federal government is, I sit on so many briefs all the time. The federal government has said that, they're going to continue to help out, but the general expectation is that eventually states are going to find a way to fund this stuff themselves. And that federal help's not always going to be there forever. So finally, opportunities for advocacy. If you have a QR code, you're familiar how to use QR codes, please feel free to scan the one that's on the screen. That's just my call to action. That's letting your state senators in Pennsylvania know that they need to support the 988 user fee and how detrimental it is and why they need to support that. Because like I said, we're not going to get this through across the finish line unless the Senate knows that we're paying attention to their lack of movement. I send emails all the time, and sometimes I get, oh yeah, we've heard about that. And then, if you'd like me to come talk to anybody on your staff, etc., please let me know. And then the conversation dies or falls to the wayside, etc. Other opportunities for advocacy: be loud about 988. Tell everybody you know about 988. I will say, in and around the Pittsburgh area, I've seen more billboards pop up. I've seen more advertisement at bus stops. And I will also say that NAMI Keystone is currently following a bill right now that would amend current legislation or amend a current title to include 988 as a point of education. And when I say a point of education, that would allow the state to expand their public service announcements regarding 988. So pretty excited about that one. Always a good day when some new legislation pops up, especially one that's designed to assist and promote 988. So, and then finally, everyone will get a copy of this presentation in your email. So here are all of my references and resources with hyperlinks. So that way you can go in and, if for some reason, you want more information, there's all of that information at your disposal. If you're a provider, and you're listening to this webinar, there's toolkits, how you can promote 988 within your practice, etc. And then of course, questions.
So
I
Nikki,
see there's one in the chat.
there is. And the question is, with the wait lists for IVH, well, for behavioral health services across the state, many situations escalate and youth are all too often do not have needed coping skills. Do you have any suggestions while you wait tools you would recommend?
That's a very loaded question and something that we talk about frequently at NAMI, because children's services, the adult services are bad, children's services are worse. And talking about, getting peer support across the lifespan has been one of NAMI's big goals, because we recognize that the way peer support is currently set up, it's, usually like 18 to 65. We don't have any senior citizens that are out there supporting their peers as they work through mental health. We don't have systems set up for youth peers, things of that nature. So I don't rate off the top of my head, but I will look more into that, and I will send my response when I email everything to Patty and Maria. And thank you, Elsie, for the compliment. I appreciate it.
Great.
Does anybody else have any other questions?
I don't see any other questions right now either, but that was a fantastic presentation. Thank you, Nikki and Jenny, so much. And certainly, you had your contact information up. I'll be glad to share my contact information as well. So if people, missed yours or wanna, let me just pull our information up as well. We're happy to answer any questions as well, or let me just get it, or direct people to you guys, and your contact information. But that was so much good information. And like I said earlier, we work with a lot of families, with a lot of different disabilities, and we're always, willing and happy to share your contact information and that of NAMI, because you guys have helped so many people. And just through the years, you've been such a great friend to Achieve a Family Trust and supporting us and the families we serve. So thank you very much for this presentation and all the time you guys took out of your schedule. And I think there might be, I see another question up there. Someone said that they had a similar crisis experience as you had with your family member in Florida, and her phone 988 called Resolve in Pennsylvania, and that caused the helper to do her best, but resulted in a very difficult scene. Is there any way 988 can be improved beyond pings?
So overall, the goal eventually would be fantastic to get to where we're just like we're at with 911, where they can track your phone. However, due to privacy concerns and the stigma surrounding mental health, and that being a potential escalator or trigger for somebody in that mental health crisis, it's not being talked about as an immediate solution. They are working very hard on the geo routing thing. The FCC has authorized that for 988. They've already had the regulations open for public comment. Of course, we provided comment on that. It's just a matter of getting it into place at this point to where that you're going to ping off the closest cell phone tower to you, and that's where you're going to be connected. Because if you're calling for a family member, it's easy enough for you to say, hey, yes, I have a 412 number, but I'm currently in Florida. Can you please connect me to the closest crisis call center there? However, again, somebody in a mental health, behavioral health crisis isn't going to necessarily be within that frame of mind to be able to tell somebody that they're not where their cell phone number is. They're not in West Virginia, they're not in Pennsylvania. So somebody calling from a 412 number in California that's in college and having a crisis, they may not be able to communicate that effectively, that they're not actually in Pittsburgh where their cell phone number populates. So we're working towards that as a whole, and like I said, it's federally mandated at this point. It's just a matter of the cell phone companies rolling it out and the regulations being designed. So hopefully we'll have some more positive outcomes on that within the next year.
Thank you. That never even occurred to me what an issue that can be, because nowadays so many people do have cell phone numbers from, that have different area codes all across the country. So I'm glad you guys are, obviously aware of it and addressing it. So.
Yeah, absolutely. I mean, I'm a good example of that. Like I mentioned, I was in the Army. When I first moved back to this area in general, I had a 210, which is a San Antonio number, for years. And then finally something happened and forced my hand to get a phone number changed. And I did so begrudgingly. But yeah, I mean, for 6-7 years, I had a San Antonio area code.
Well, yeah, I know. I know so many people who still live all across the country and still have 412, the Pittsburgh.
Yes. You pride yourself in that phone number. It's like almost part of your identity.
It is. It's a lot of work to change phone numbers.
Especially being from the 412 area code. I know that carries a certain amount of pride with it. So.
Well, thank you. Thank you both again so much for your time and spending this morning with us. I thought there were a lot of great questions.